This lecture will cover prescribing considerations for older adults. By the end of this lecture, I hope you can describe one physiologic change that occurs in older adults, name 3 common adverse drug reactions in older adults, define polypharmacy, describe the risks associated with it, and develop a plan to prevent and manage it, name 2 guidelines for safer medication use in older adults, and list 3 medications which are potentially inappropriate for older adults and recommend therapeutic alternatives. I'm sure that you have all seen older adults in your practice. I probably don't need to explain to you how important these issues are. About 40 million U.S. citizens are above the age of 65. This number is expected to increase to 72 million by the year 2030. More than 3/4 of seniors between the ages of 65 and 79 suffer from one or more chronic diseases. This number increases to 85% for those who are above the age of 80. On average, adults between the age of 65 and 69 take about 14 prescriptions per year. This number increases to roughly 18 prescriptions per year for those between the ages of 80 and 84. You will see these patients in your practice, and they will be on medications. So having a good understanding of how to appropriately use medications in the older adult can make things safer for each individual patient. So what happens as we age? Next, we'll discuss some of the pharmacokinetic and pharmacodynamic changes that can occur in an older adult. For pharmacokinetics, we'll discuss the differences in absorption, distribution, metabolism, and elimination. Typically, the changes in absorption are not statistically significant. However, they are important to be aware of as we prescribe or recommend or monitor medications in the older adult. In our mouth, we can have a decrease in saliva production. In our skin, we can have a decrease in blood flow as well as thinner skin. This is similar to some of the overall absorption changes that we can see where we have cellular atrophy and a decrease in blood flow. This decrease in perfusion can change our absorption of intramuscular and subcutaneous injections, as well as transdermal products because of those skin changes. In our stomach, we can have a decrease in hydrochloric acid secretion. This is also known as achlorhydria. This can cause an increase in gastric pH. This is going to lead to a decrease in absorption of basic medications. Basic medications are those that need an acidic environment in order to be best absorbed, and they include ferrous sulfate, calcium carbonate, and ketoconazole, among others. We also can have a decrease in peristalsis and gastric emptying within the stomach. In the small intestine, we can have a slowing of transit time. This decrease in GI motility can change the rate and extent of absorption of extended release products, as well as certain medications such as levodopa. So to summarize, our changes in absorption include achlorhydria, a decrease in gastric motility, and decrease in tissue perfusion. From a distribution perspective, we have a decrease in skeletal muscle or lean body mass, as well as a decrease in total body water. These can cause an increase in volume of distribution for water-soluble drugs such as digoxin, theophylline, and lithium. We also can have an increase in adipose tissue or total body fat. Because of this, we can have a prolonged duration of action for lipid-soluble medications such as diazepam. As an example, the half-life of diazepam in a young adult is about 25 to 30 hours. However, in an older adult, this number increases to anywhere between 60 and 100 hours. So the cognitive effects of diazepam can last for days in an older adult because of their change in body composition. We also have a decrease in proteins, a change in proteins. We can have a decrease in albumin and an increase in alpha-1 acid glycoprotein. Because of our decreased albumin, we can have less protein binding of highly protein-bound medications such as warfarin and phenytoin. This will result in more free drug, leading to more effect. To summarize our distribution changes, we can have a decrease in total body water, a decrease in lean body mass, an increase in body fat, as well as a decrease in serum albumin. From a metabolism perspective, we have some changes within the liver. We're going to have a decreased liver size, decreased liver blood flow, resulting in a decreased liver function. We also have a decrease in the liver's ability to recover from injury. Because of all of these things, we can have a decrease in metabolic clearance of certain medications. Typically, we will see a decrease in phase 1 metabolism, medications which undergo oxidation, reduction, or hydrolysis. These include medications such as amitriptyline, diazepam, meperidine, diphenhydramine, ibuprofen, warfarin, and phenytoin, among others. Phase 2 metabolism is not affected by age. The benzodiazepines lorazepam, oxazepam, and temazepam, I think of the mnemonic LOT or LOT, depend on phase 2 metabolism. Because phase 2 metabolism is not affected by age, these 3 benzodiazepines are safer to use in an older adult. Cytochrome P450 enzymes are typically unchanged. Some studies do show an increase in metabolism, some show a decrease in metabolism. So there is some intra-individual variation in cytochrome P450 enzymes, but overall it is thought that these pathways are typically unchanged. By far the most important pharmacokinetic parameter which changes as we age is that of elimination. We have a decrease in glomerular filtration because of a decrease in mass, including glomeruli, a decrease in blood flow, a decrease in filtration fraction, decrease in tubular secretion. All of this is going to decrease the clearance of some medications, specifically those that are renally eliminated. These medications have the potential to accumulate, as well as their metabolites, which can cause an increase in adverse effects of renally eliminated medications. This is by far the most important parameter. You should always adjust medications for renal function in an older adult. At age 85, our creatinine clearance is about 50. Start our older adults on medications that are prescribed at a lower dose than what you may see in a younger population. We also want to slowly titrate these medications up until we get the appropriate therapeutic response. I've also heard this mantra as start low and go slow, but go. I have seen some patients who are started on a low dose of medication and are never titrated up to that appropriate therapeutic response dose, partially because of inappropriate follow-up and monitoring. So always remember to assess medication dose and therapeutic response to determine if doses need to be adjusted. Second mantra that I use is always suspect a medication until proven otherwise. And this relates to adverse drug reactions. So what is an adverse drug reaction? This is any response to a medication which is noxious, unintended, and which occurs at doses normally used in humans for prophylaxis, diagnosis, or treatment of a disease. There is a direct correlation between the number of medications that a patient takes and the risk of ADRs. In older adults, about 30% of hospital admissions are related to adverse drug reactions. Older adults are 4 times more likely to experience an adverse drug reaction than a younger adult, and 27% of adverse drug reactions in primary care and 42% of these ADRs in long-term care are preventable. Most problems occur at the ordering and monitoring phase. So what are our risk factors for developing an adverse drug reaction? The number of medications is the number one risk factor. And this is because of additive toxicity and drug-drug interactions. As the number of medications a patient is prescribed reaches 8, the risk of a drug-drug interactions approaches 100%. Think of the number of patients that you've seen in your practice who are taking 8 medications on a daily basis. There's quite a few of them. In one study, about 5 to 15% of patients experienced an adverse drug reaction as a result of a drug-drug interaction. It's also important to think about not only drug-drug interactions that increase our efficacy, but also those that may reduce efficacy of medications, because they may lead to unnecessary dose increases or addition of other medications which aren't needed. About 50 to 60% of adverse drug reactions in older adults are because of the wrong dose, going back to that start low and go slow mantra. Lack of monitoring in patients also includes lack of patient education. Patients and caregivers should also be educated on what to watch for after they're starting on a new medication or with dose increases. So which medication should raise a red flag for you? Anything that's new. If you're seeing a patient in follow-up or they're calling with new questions or concerns, I always look at their newly started medications first, because this is most likely to be causing something or be causing some problems. Potentially inappropriate medications, which we'll talk about a little bit later. Narrow therapeutic index medications, or anything that we can draw drug levels on, and then other drug classes are listed here as well. The two big groups that cause the biggest concerns or biggest problems are anticoagulants. This includes both warfarin, our novel oral anticoagulants, and oral antiplatelet agents, as well as hypoglycemics. So our oral hypoglycemic agents such as sulfonylureas and insulin. What are some of our leading adverse drug reactions in older adults? They're more likely to experience severe hypoglycemia, electrolyte imbalances, bleeding, delirium, falls, and renal failure. I feel like we can't discuss adverse drug reactions in an older adult without discussing anticholinergic effects. Anticholinergic effects occur because of medication effects at the muscarinic receptor. This picture highlights where muscarinic receptors are located within our body. But I always use the acronym anti-sludge, or the mnemonic anti-sludge, to think about anticholinergic effects in older adults. Sludge stands for salivation, lacrimation, urination, defecation, and gastric emptying. Sludge effects can occur with cholinergic medications. So with anticholinergic medications, we would expect to see the opposite. So dry mouth, dry eyes, which can cause blurry vision, urinary retention, constipation, and a slowing of gastric emptying. All of these side effects can be particularly troublesome in an older adult, where they may have some of these things underlying anyway. Another way to look at this, or other adverse effects that can be associated with anticholinergic medications, include confusion, falls, increased intraocular pressure, oversedation, orthostasis, and cardiac arrhythmias. So you have a patient who presents with falls. Which of the following medications from their list is the least likely culprit? Acetaminophen is the correct answer. All of the other agents have the potential to cause falls. Glyburide can cause hypoglycemia, which can cause a fall. Captopril can lower blood pressure. Amitriptyline has anticholinergic effects. Furosemide can also cause a decrease in blood pressure, electrolyte abnormalities, or some urinary incontinence, all of which could contribute to a fall. The next mantra that I use when thinking about medications for older adults is one disease, one drug, once daily. And this relates to the concept of polypharmacy. So this is from Dr. Seuss, his book, You're Only Old Once, a book for obsolete children. I think it gives a great humorous look at polypharmacy. He states, a voice will instruct you, repeat after me. This small white pill is what I munch at breakfast and right after lunch. I take the pill that's Kelly green before each meal and in between. These Loganberry colored pills I take for early morning chills. I take the pill with zebra stripes to cure my early evening gripes. These orange tinted ones, of course, I take to cure my Charlie horse. I take 3 blues at 8:30 to slow my exhalation rate. On alternate nights at 9 p.m. I swallow pinkies, 4 of them. The reds, which make my eyebrows strong, I eat like popcorn all day long. The speckled browns are what I keep beside my bed to help me sleep. This long flat one is what I take if I should die before I wake. So it seems like a pretty humorous perspective on polypharmacy, but I'm sure that some of us as providers may sound like this when we talk to patients because they may not have a clear understanding of what they take and when, and all of it can be pretty overwhelming. So what polypharmacy? Polypharmacy is very difficult to define because there are multiple definitions within the literature. I've listed some of those definitions here for you. So the use of 2 or more drugs without indications or for the same purpose, using a drug to treat adverse reactions of another drug, using 2 or more drugs of the same class or with similar action to treat different conditions, or when there are more medications used to prescribe than clinically indicated. There are also, I've also seen definitions for minor polypharmacy, which is thought to be anywhere between 2 to 4 medications on a daily basis, or major polypharmacy, which is taking 5 or more medications on a daily basis. European studies typically define polypharmacy by the number of medications prescribed. U.S. studies typically define it based on indication. AGS, or the American Geriatric Society, does recognize that there are multiple definitions, but they choose to use the number 5. So AGS states that 5 or more medications taken daily is considered polypharmacy. Polypharmacy is iatrogenic. This is something that we do to our patients. And if you look at guidelines, it kind of makes sense because if you have an older adult who has 5 chronic conditions, they could take 13 medications. This can cause problems with adherence. It increases medication burden and cost, and there's an increased risk for adverse drug events and drug-drug interactions. The number of medications taken directly correlates with the increased risk of ADRs. And you've seen the number 8.6. There's an 8.6% increase in ADRs for each additional medication which is added to a patient's regimen. We may be seeing more polypharmacy now because of longer life expectancies. Our patients are living longer. They may experience more chronic disease because of this. There are also more medications available. We also have some concerns related to polyprescribing. So patients may see multiple providers, and some of this is because of the greater utilization of specialists. Patients may also go to multiple pharmacies. This is potentially lack of education or convenience because they're seeing multiple providers. They may see providers in different clinics. They may fill at pharmacies that are closer to each of those clinics. There's also not enough communication or some hesitation to make changes that were on things that were prescribed by another provider. So if a patient sees their primary care provider, the primary provider may not be willing to make changes to things that were prescribed by cardiology. And because of those challenges in communication between specialties, medication changes may not get addressed or may be overlooked. Guideline recommendations also often lack age-specific evidence. Frequent hospitalizations can increase our risk for polypharmacy, so there may be errors made at medication reconciliation across the transitions of care, and then self-medication can also increase our risk for polypharmacy as there are more over-the-counter products available now. There's also more public awareness of health-related issues because of the internet and direct-to-consumer advertising. We generally have a more educated public. Polypharmacy can lead to noncompliance, adverse drug reactions, and falls. Those three are in bold because they are the top three consequences that were cited by the specific authors that are cited on your slide. With polypharmacy, we also can have an increased risk of hospitalization, more medication errors, an increase in cost, and drug-drug interactions. So as healthcare providers, what can we do to help? We should always be carefully assessing current medication use, and typically this includes a good medication history. We need to make sure we're including prescription products, over-the-counter products, herbal, non-oral routes. We also can think about our prime questions. This is a way to assess the patient experience, their expectations, and their concerns related to medications. We should always be assessing adherence. If patients don't give us a direct answer, or we don't necessarily believe their answer related to adherence, we can use adherence clues, such as how well organized are they with their medications? What's their patient understanding? Can we use a refill history from an outpatient pharmacy? So on to critically evaluate all new medications. Were these appropriately prescribed? Are they the right dose? Is the patient experiencing any adverse effects? We need to understand the goals of therapy. Oftentimes this will include or should include a discussion with the patient or their caregiver. We need to think about life expectancy and determine, is our goal in prescribing a specific medication to maximize longevity, or is it more for palliation or comfort? We should always be matching each of the patient's conditions to their current medications. We can consider tapering or discontinuing any medications that may mismatch. We always want to only make 1 to 2 medication changes at a time. We want to make sure we're reconciling medications across the continuum of care. Be aware of potentially inappropriate medications and adverse drug reactions. Communicate with other disciplines, educate patients and caregivers, and always remember to have close monitoring and follow-up. The Medication Appropriateness Index is a 10-question assessment that has been validated across the levels of care, and it includes the 10 elements that are considered necessary for appropriate prescribing. It can be used in all settings. However, it can be subjective. It can take a while, as in theory, the Medication Appropriateness Index is supposed to be used for each medication that a patient is taking. However, I think that it's important to just kind of think about these questions on a global level when we're looking at a patient's medication list. So we should be thinking, does every drug have an indication? Is the medication effective for that indication? Is the dose correct? Are the directions correct? Are the directions practical? Is it something being prescribed 3 or 4 times a day when we have an alternative that could be taken significantly easier or less frequently? Are there clinically significant drug-drug or drug-disease interactions? Is there any unnecessary duplication with other medications? Is the duration acceptable? And is it the least expensive alternative? So let's patient case. We have our 78-year-old female, ML. You're seeing her for the first time today. She's healthy, new to the area, wants to establish medical care. She has diabetes, hypertension, and GERD. She just moved in with her daughter. Her daughter does help her with medication. She takes metformin, pioglitazone, ciprofloxacin, pantoprazole, hydrochlorothiazide, aspirin, Tums, Oscal plus D, iron, Docusate, and Senecot S. The left column are medications which are prescription. The right column are those that are over the counter. The patient is self-managing all of these medications. She hasn't been seen by a physician in the last 12 months. Have been no medications or no changes to her medications since that time. She doesn't have any acute medical complaints. She's really just establishing care. Her vitals and labs are all normal. So let's reflect. Is this polypharmacy? Yes. She's taking 5 or more medications. She does have 2 or more medications which are for the same indication. We have some medications which may be treating adverse reactions, and we do have 2 or more drugs from the same pharmacologic class. So by multiple definitions, this is polypharmacy. Because the Medication Appropriateness Index, or the MAI, is the most thorough, I'd like to apply the questions from the MAI to her medication list. This is going to help us to identify any problems and potentially determine a plan to simplify some of her medications. Ideally, each question is going to be applied to each medication, but we're just going to be general, kind of apply it globally to her whole medication list. So remember, she has diabetes, GERD, and hypertension. So is there an indication for each medication? Why is she taking the Cipro? Why is she taking iron, calcium, Colace, and Senokot S? Is the drug effective? Everything that's indicated based on her past medical history is effective. Are her medications being prescribed in the correct dose? So the metformin dose is low. 500 milligrams once a day is lower than what we would expect. Hydrochlorothiazide, 50 milligrams daily. We could potentially consider a dose decrease for that. Are the directions correct? For the most part, yes, although typically metformin is prescribed twice a day, so that could be a concern. Maybe she was started on once daily therapy and it was never increased. And then are the directions practical? For the most part, yeah. Cipro is every 4 hours, may not be very practical, although we're wondering why she's on that anyway. Iron she takes 3 times a day. Again, probably not the most practical, but again, we're questioning why is she taking this medication anyway. Otherwise, all of her medications are just dosed once daily. Oh, I take that back. The Tums as well as TID. But again, we don't know why she's taking that. We don't specifically have indication. And it's a self-managed medication. All right, so are there any clinically significant drug-drug interactions? The answer to this question is no. What about drug-disease interactions? So she does have GERD. Aspirin may be interfering with her GERD. We could consider an enteric-coated aspirin or decreasing the dose of aspirin. Are the medications cost effective? Is this the least expensive alternative? There are some medications which could be potentially changed. Actose or pioglitazone may not be the least cost effective. Pantoprazole or Protonix may not be the least cost effective. Is there unnecessary duplication of therapy? So she is taking Colace and Senokot S. Are both of those needed? She is taking metformin and Actose. The metformin is not at an optimized dose, so we could potentially optimize the dose of that. She's taking Tums and Oscal plus D. And then is the therapy duration acceptable? So Cipro eye drops. When was this prescribed? Is it really true that she's been using this for the past year? When should this be discontinued? The next mantra that I think of is less is more. Here I'd like to describe a little bit more about the prescribing cascade. So the prescribing cascade is the concept that medications are prescribed to treat adverse effects of other medications. So we always need to think that when patients present with a new problem that it's an adverse effect from another medication. So here's an example of the prescribing cascade. Patient develops insomnia. They decide to self-treat over the counter with diphenhydramine. This may cause worsening cognition. Patient may present to clinic with complaints of worsening cognition. It may be deemed appropriate to start the patient on donepezil. Donepezil can cause urinary incontinence. Back to the clinic with complaints of urinary incontinence, prescriber decides to add oxybutynin. Oxybutynin is a highly anticholinergic medication, which can cause a myriad of side effects, so it's anyone's guess what she's going to present with next. This all could have been prevented if we had recognized the anticholinergic effects of diphenhydramine that the patient was using over the counter. Common examples of the prescribing cascade. NSAIDs can cause hypertension, so this may lead to the unnecessary addition of antihypertensives. Thiazides can cause gout, which may lead to new gout meds being added. Amlodipine and nifedipine can both cause edema. Potentially this isn't recognized as a side effect, and diuretics are added on. Take a few minutes to think about what other prescribing cascades you may have seen in practice. The next mantra that I use when dealing with older adults is stop more drugs than you start. This brings up the of deprescribing. Deprescribing is tapering, withdrawing, or discontinuing medications to reduce polypharmacy, adverse effects, and inappropriate or unnecessary medication use. It can improve the quality of life while still maintaining control of chronic conditions. It does need to include continual reevaluation of ongoing need for and effectiveness of medication therapy. It needs to be done with close monitoring to avoid worsening of disease or withdrawal. When possible, utilizing an interdisciplinary approach for deprescribing will be helpful. You need to prioritize and determine your course of action. Are you going to discontinue the specific medication, taper a medication, just try to reduce the dose, consider a substitution with a safer alternative, or recommend non-pharmacologic approaches? We only want to make one medication change at a time. This way we'll be able to identify specifically how the patient reacts to that medication change. If we change more than one thing at once, it becomes challenging to identify what made the difference or what's contributing to the next set of either problems or improvement. You want to recommend clear discontinuation or tapering regimens, especially when you're educating the patient on what they're supposed to do with their medication therapy. You should be considering simplifying the medication regimen. You always want to involve the patient and caregiver. Sometimes it's challenging to get buy-in from the patient and caregiver, so highlighting the benefits and really getting the patient or the caregiver to buy into what you're trying to do to improve the patient's quality of life or safety related to medications is really important. And then we also want to have very close follow-up. For those who are more visual, this basically is a diagram of what we've just talked about. So when you're trying to minimize medications, you can identify medications that you're going to target for deprescribing. Ideally, you want to discontinue those. If you're unable to discontinue them, you can consider either reducing the dose or tapering. If we taper, we want to only taper one medication at a time, and you can use the general rule of thumb of decreasing the dose by about 10 to 25% every 1 to 2 weeks. And if neither of those options are feasible, you can consider safer alternatives for specific geriatric syndromes. So as an example, we've got a patient who's admitted to the hospital. She takes acetaminophen, ciprofloxacin, lisinopril, or pravastatin without knowing anything else about the patient. Which medication do you want to further investigate to identify if deprescribing would be appropriate? Ciprofloxacin would be the first one that I would want to investigate to identify when was this medication started, what's the appropriate duration of therapy, and how long should it be continued. Next, we'll discuss potentially inappropriate medications. Potentially inappropriate medications, or PIMS, are medications in which the risks generally outweigh the benefits in older adults. Many of them have limited benefit, and there are safer alternatives that have fewer adverse effects. The list in the column on the right-hand side is not all-inclusive of medications which are PIMS, but many of these drug classes are considered PIMS in older adults, and they should raise a red flag for you. These include anticholinergics, first-generation antihistamines, tricyclic antidepressants, antipsychotics, benzodiazepines, non-benzodiazepine hypnotics, GI and GU antispasmodics, muscle relaxants, and NSAIDs. Remember that these are potentially inappropriate medications, so at times they may be appropriate. It's important to treat each individual patient, consider all aspects of their therapy when recommending drug therapy. PIMS may be appropriate for short-term use. If we are going to use them, we want to make sure that we're using the lowest possible dose. When possible, we want to use them on an as-needed basis and for shortest duration possible. We should also be using them with careful and diligent monitoring. They should never be your first choice in the outpatient setting. And we also need to keep in mind that circumstances may change for patients where a medication that was once appropriate is now inappropriate due to adverse effects, interactions, etc. There are several PIM lists available The two that we'll focus on today are Beers criteria and then start and stop. Beers criteria is a list of potentially inappropriate medications in all ambulatory and institutional settings of care for populations age 65 and older in the United States. It was developed by Mark Beers and has been updated several times over the years. The goal of Beers criteria is to improve care of older adults by reducing their exposure to PIMS. It was most recently updated in 2015. It was developed by an interdisciplinary panel of 11 experts in geriatric care and pharmacotherapy using the modified Delphi method. Start and Stop was created by an expert panel in 2007. START is the screening tool to alert doctors to right treatment, and it consists of 22 evidence-based prescribing indicators for commonly encountered diseases in older adults. STOP is the screening tool of older persons' potentially inappropriate prescriptions, and it's comprised of 65 clinically significant criteria for potentially inappropriate prescribing in older adults. Within your course materials, you will find copies of Beers criteria and several other associated readings, as well as the start and stop criteria. In addition, you will find an assessment, which I would like you to complete, which will kind of walk you through and ask you to utilize both Beers criteria and the start and stop criteria, and apply it to patient cases and just answer general questions about each resource. Pause to complete this, and then feel free to come back to the lecture, and we will talk through the answers. So the first 4 questions relate to our patient case and Beers criteria. So our patient case is Mrs. Jones, a 78-year-old female who has moderate Alzheimer's dementia, hypertension, and high cholesterol. She came into the hospital 3 days ago and is now getting ready for discharge. She was admitted with a UTI, received IV antibiotics. She's returned to baseline functioning. The physician wants to prescribe nitrofurantoin, prochlorperazine, and zolpidem on discharge. The physician asks you to carefully review discharge meds for Mrs. Jones. So utilizing Beers criteria, which of the following of Mrs. Jones's medications may be potentially inappropriate? The correct answer here is A, 2 and 4. Pantoprazole and diphenhydramine may be inappropriate. Pantoprazole should only be short-term for patients who have appropriate GI diagnoses, such as GI bleed, due to its potential for adverse effects, such as C. diff, electrolyte abnormalities, etc. Diphenhydramine is not recommended in older adults because of its anticholinergic effects. After reviewing the patient's new prescriptions, which of the following does not need to be addressed prior to discharge? Correct answer here is A. The patient's creatinine clearance is about 40 mL per minute. Nitrofurantoin may not be effective as it may not reach the site of action and may increase the patient's risk for pulmonary toxicity. So remember, this is a negative question looking for which one does not need to be addressed prior to discharge. Nitrofurantoin used to not be recommended in patients who had a creatinine clearance under 60 mL per minute. However, now that recommendation has been reduced, it should only be avoided in patients who have creatinine clearance under 30 mL per minute. So you do need to assess renal function when prescribing or reviewing patients who are on nitrofurantoin. However, it is now able to be used in patients who have slightly better renal function than was previously recommended. We are not recommending, or Beers criteria does not recommend the extended use of proton pump inhibitors. Prochlorperazine is anticholinergic and may worsen the patient's dementia. Zolpidem should be avoided in older adults. Sleep hygiene and lavender would be recommended first. And ibuprofen and diphenhydramine are also considered potentially inappropriate medications. The patient's daughter is very involved in her mother's care and would like to discuss the medications her mother takes with you before discharge. Which of the following will you educate the patient and her daughter on? Correct answer here is D. Diphenhydramine should be avoided in the elderly. It can worsen dementia, increase the risk for falling, and may not be as effective over time. Because of concerns with diphenhydramine and zolpidem, what do you recommend for this patient if a sleep agent is needed? We've kind of already talked about this one. A is the correct answer. Non-pharmacologic approaches such as sleep hygiene and lavender would be recommended first line. All of the following should be avoided in patients with a history of falls, except, correct answer here is D. Beer's criteria does separate out PIMS based on just medication classes and then also in conjunction with specific patient diagnoses. So you can utilize the falls diagnoses tables to find the correct answer to this question, and everything should be avoided except trazodone as far as what's on for this question. Which of the following statements regarding antipsychotic use in the elderly is false? Correct answer here is B. First generation antipsychotics should be avoided in geriatric patients. However, there are very similar risks with second generation antipsychotics. Both first and second generation antipsychotics should be avoided in older adults because they can increase the risk of stroke. And they are associated with a greater rate of cognitive decline in patients with dementia. There also has been an increase in mortality when they're used for treatment of behavioral problems associated with dementia. Which of the following renal dose adjustments and rationale are correct based on the 2015 update to the Beers criteria? The correct answer here is E, 1 and 3, rivaroxaban and famotidine. Those pairings of drugs and creatinine clearance are appropriate or are correct. Which of the following is not a potentially clinically important drug-drug interaction based on the 2015 update to the Beers criteria? The correct answer here is C, ACEs and loop diuretics. The next set of questions, you are asked to utilize the STOP criteria. According to STOP criteria, a patient with Parkinson's disease should not receive which of the following medications? Correct answer here is metoclopramide. Metoclopramide has the potential to irreversibly worsen a patient's Parkinsonian symptoms. According to STOP criteria, NSAIDs may exacerbate all of the following conditions except gout is the correct answer here. NSAIDs would be appropriate to use in a patient with gout, but NSAIDs can exacerbate hypertension, CHF, peptic ulcer disease, and chronic renal failure. According to STOP criteria, this medication should be used as first line for gout unless contraindications are present. Correct answer here is A, allopurinol. Patient is admitted to the hospital following an elective hip replacement surgery. Her chart reveals a past medical history of COPD, diabetes, chronic constipation. Based on her current diagnoses and the STOP criteria, which of the following would be appropriate medications for the patient to receive? The correct answer here is nebulized ipratropium. Next, you are asked to use the START criteria. 73-year-old female is admitted with a fracture after a fall. Which of the following should you consider starting? Correct answer is calcium and vitamin D. You note that one of your older adults has CHF. You note their recent ejection fraction was 35%. START criteria recommend that all patients with CHF should receive the following medication or medication class. Correct answer here is an ACE inhibitor. You are caring for an 84-year-old male who presented with weakness, confusion because of a UTI. You note his past medical history is significant for coronary artery disease, hypertension, diabetes, and hyperlipidemia. What specifically are you looking for when you review his medications? The correct answer here is all of the above. He should be on an ACE or an ARB if he has diabetic nephropathy, proteinuria, or microalbuminuria. He should be on aspirin. He should also be on a statin or have contraindications to both of those therapies. START criteria recommend that all patients with AFib should also receive B, warfarin, aspirin, or a direct oral anticoagulant. And these last two questions are just general questions that relate to Beers and START and STOP. So which of the following statements regarding the Beers criteria and START and STOP criteria are correct? Correct answer here is E, 2 and 3. So medications included in the Beers criteria have been found to be associated with poor health outcomes in the elderly. Medications in the STOP criteria are significantly associated with adverse drug events. The Beers criteria has not been proven more accurate than start and stop. There have been several studies that have compared the two. There have not been shown to be any statistically significant differences yet, although there is a potential trend that the start and stop criteria may pick up a little bit more, maybe a little bit better in identifying issues with older adults. However, this is only a trend. It is not statistically significant at this point, and neither criteria is recommended over the other. Which of the following statements regarding utilization of the Beers criteria is correct? The correct answer here is C. Important recommendations and caveats are included in the criteria and require consideration before changes in therapy are made. So again, these are potentially inappropriate medications. They should be very patient specific. You should consider them when making recommendations to or changes to patients' medication therapy, but these are not black and white guidelines. So a few patient scenarios for you to consider. A healthy 67-year-old male calls the clinic with complaints consistent with seasonal allergies. What do you recommend? Diazepam 10 milligrams times 1 is ordered for a 93-year-old frail female who's going for an MRI. Is this appropriate? A 74-year-old male on warfarin for atrial fibrillation. His INR is therapeutic. He has no signs or symptoms of bleeding. You see him today for osteoarthritis pain. He's been self-treating with acetaminophen with little response. What are you going to recommend? And then we have a 76-year-old female who develops delirium postoperatively. Non-pharmacologic strategies have failed. What dose of haloperidol would be appropriate? Parting thoughts for you. You should always be considering if medication choice is appropriate. We need to be assessing both appropriate dose and frequency for older adults, always taking renal function into consideration. We should be identifying and evaluating the use of any PIMS. Are we using the lowest effective dose? Is the patient tolerating it? Is it scheduled or PRN? If it's scheduled, can it be PRN? Are there alternatives, and can we consider deprescribing this potentially inappropriate medication? We need to think about drug-drug and drug disease interactions. Think about adverse effects. Keep things as simple as possible. We also need to always involve patients and caregivers and educate them on their medication. Always remember, growing old isn't for sissies. We can do, there are a lot of things that we can do to help our older adults use their medications safely.